Ladies and gentlemen, I think the video speaks for itself. And a word of thanks to those people with RMDs and their families who contributed in such an extraordinary way to sharing their message. I think all of you will be as moved as personally I am, and I've actually seen the video before. So what do we do as a community in response to this assault on the lives of individuals, their families, and the impact that has in our society? Well, EULAR has created a vision at this utterly crucial time in the life cycle of the EU and its member states. New MEPs, a new Horizon programme, new opportunities to innovate and bring enterprise to change lives. And so our vision is to bring health, chronic disease, and the RMDs with their rightful place in that group of illnesses absolutely to the fore in the minds of policymakers. Issues of health should permeate every element of policy and design for society. From green buildings and a safe environment, as Teresa brought us earlier today, all the way through to a safe workplace, as Antonio so very clearly defined for us. And to, of course, the future of therapeutics, which will in the end be curative, but at the moment are not. And we must recognize that reality. And so our vision is to put health absolutely at the center of the minds of those writing policy for us, and achieve policy that is sustainable. We are sometimes told that our political friends seek short-term solutions. That clearly cannot work with a lifelong disease, and so we must work with them to set goals that we know set us on the right journey. There is a proverb which is claimed by the Scots, the Irish, and the Chinese, and I suspect by every nation in this room. Every long journey starts with a single step. So let's make the right steps today. This is what EULAR is asking for in its vision. The integration of health into all policies, you will appreciate and understand, means that we must be very broad in our reach, broad in our exercise of influence. We no longer live in the health box. And I think actually when you look at the way in which the new policies are written, it is implicit that health will now be contained in very many domains and areas of policy setting across and around the EU. We must particularly focus on the outcomes, that is, what the achievement of health and well-being. Increasingly in medicine, I am a physician, we are focusing on wellness rather than illness. Policy must reflect that. EULAR believes that very strongly. And then we have to strengthen the way in which that impact manifests across member states. Written tomes are fine. Libraries are wonderful, but they're of little value if people do not walk through the door. And it's quite easy to walk through the electronic door now of knowledge, but it requires all of us and those listening around the world as we stream to the world to take up that important message. So we actually seek impact on health policy. We seek outcomes that matter and make a difference for people now, for people who do not yet have RMDs, although we know there are many millions in Europe who sadly will have RMDs soon. But this is not a hopeless situation, quite the contrary. The last 2 decades have seen extraordinary changes in the way in which we can understand and treat, and particularly in the medicines available to us and in the strategies whereby we use those medicines. If we continue this exponential journey of discovery, enterprise, and innovation, it's impossible not to be optimistic. So this is not a depressing message that EULAR is bringing. Quite the contrary. We bring the opportunities to the policymakers so that they really will exert impact. The framework on health impact assessment, therefore, is really something to which we must speak. we deeply respect and emphasize the focus, for example, on cancer, on antimicrobial resistance. But here's a very salient fact. Multimorbidity is now the norm. The days of a single disease for a single individual are long since gone. As our demographics change, so multimorbidity, defined as the presence of 2 or more chronic diseases in one individual, is the norm. And thinking of an individual disease condition in the context of chronicity, thinking that solving cancer will solve the problem, of course it's vital, as is cardiovascular management. But we would contend that failing to deal with the RMDs will inevitably lead to failure across the spectrum of wellness. And of course, there's no point in having policies, there's no point in having medicines, enterprise and innovation if we don't allow people to access that. And so EULAR is calling for improvement in access, equity of access across Europe, equity across socio-economic divides. Those who are wealthy and those who are not should have equal opportunity and equal options for wellness. And finally, if all of this comes together in your mind, and I hope it will, we now seek to put the citizen and the person with an RMD, the patient, at the very center of all policy, wherever it's set and wherever it has its impact. Ladies and gentlemen, I hope these opening remarks, especially those from Teresa, from Roberta and Antonio, to whom I extend my further words of thanks, really focus our minds on the task in hand. But we need a little help, and for that reason I'm enormously grateful to external international experts who have come to share their knowledge with us. And in that respect, it's a particular pleasure for me to welcome first to the podium Thomas Alvin from FPIA. FPIA is an organization that brings pharmaceutical industries together across Europe. Tomas knows much more about it than I do, so it's a very good time for the rheumatologist to sit down and the expert to take over. Tomas, welcome. Thank you so much.
Thank you very much. Thank you very much for those kind words, and thanks again for the kind invitations to speak at this conference. So I'm going to say a few words about generally innovative medicines and how they impact health systems and specifically in the area of chronic diseases. And I think we heard a lot already about what this means, not only for patients and people living with chronic diseases, but also for the economy of our societies, and where today the health systems face a lot of pressures from the aging population and the growing incidence of chronic diseases. And as Ian just said, people living with multiple chronic diseases is now the norm, and here we can see what will happen if we don't manage this scenario. So from the aging population, where the red line is if people live longer, which we want them to do, but they will live these extra years in ill health, and what pressure that will put on healthcare budgets, versus if we manage the trend and can celebrate that people live longer, but that they can live this extra years in good health, and the enormous difference this will make for our healthcare budgets and societies. So what is the industry doing? So the pharmaceutical industry is innovating almost as never before. We can see here the numbers of innovative medicines in late stage pipelines, so phase 2, phase 3 of clinical development in different areas, and we can, for instance, find immunology there among them, and you can see almost all areas are increasing. So there's a lot of activity in the research-based pharmaceutical industry. Of course, not all of these medicines will reach patients in the end. innovation and pharmaceutical development is a risky endeavor, and we can here see the kind of success rates in different therapy areas, where you can see there that further to the bottom, autoimmune disorders have around 11% success rate from start of phase 1 in clinical trial to actually being approved by the European Medicines Agency and then reaching patients. But also we can see that the industry is trying to focus the research on the unmet needs. And we can see here a comparison of the burden of disease, different diseases in terms of disability-adjusted life years, and how that translates in approvals by the European Medicines Agency, where we can also see that immunology and musculoskeletal disorders are also growing in importance in terms of EMA approved medicines. I mean, already today, medicines have meant a lot for people and patients in Europe. Here we can see in some different disease areas, everything from HIV to MS, cancer, and also rheumatoid arthritis, on how medicines have allowed patients to live longer and healthier lives due to innovative medicines. And specifically on the topic of RA, we can see here how new innovative medicines have greatly improved the physical well-being and functional status for patients living with this disease, as well as their work productivity compared to earlier existing treatments. And of course, this is something that needs to continue, as was said by one of the MEPs. Research needs to continue to find even better treatments and maybe at some point a cure. Medicines is not only important for the people and patients living with disease, but also for the healthcare systems and societies. And we can see here some simple examples of how vaccines and innovative medicines are saving money for the healthcare systems by avoiding, for instance, costly hospitalization. In the last Health at a Glance Europe report published by the Commission and the OECD, they estimated that just people not taking their medicines, so standard treatments for cardiovascular, diabetes, and other diseases, poor adherence leads to 125 billion euros every year lost due to unnecessary hospitalization, emergency admissions, etc. So this really shows why it's important that we keep innovating and the role that medicines play also in controlling healthcare expenditures in other part of the health system. Yes, here we can say again specifically on RA, how new medicines have contributed to people living with the disease can actually be active in the work life longer, and which also have an impact, of course, can have on their pay. So incredibly important for people living with this disease. And we can see this across areas, also in cancer, how new medicines can allow people to go back to work. And when we see here the examples of Alzheimer and Parkinson's, this is future projections on how much could be saved if we get new treatments against dementia, Alzheimer's, that will actually halt the progression of these diseases for a couple of years, and how much could be saved. Or alternatively, if we can't find these new treatments, how much more pressure health systems and our economies will be under in the future. Now, it's of course not enough just to do research and innovation. These medicines must reach health systems. They must reach patients, and access to healthcare, equal access to healthcare and treatment was already mentioned. It's incredibly important, and there is a number of areas where we need to work together more: industry, health systems, policymakers, patients, to ensure that new innovative treatments can reach patients and people living with diseases. And here's a number of areas, and I'm not going to do a deep dive in all of them, but we need to make sure that our regulatory system is up to par, that you can use new evidence, real-world data for regulatory purposes, and also for payers to address whatever uncertainty is when they are going to pay for a new medicine, so that it quickly can reach patients. It's also about valuing and rewarding innovation. We must make sure that treatments that add value for patients are rewarded, and that patients, what is important for patients is at the heart of health systems, and what is rewarded and paid for in healthcare. And we also sometimes must adapt our financing models, and I will come back to that more in detail in a second. But it's also about really developing the infrastructure to support care delivery, really optimizing patient pathways and treatment strategies, and having new, and we talked about digital health just a moment ago, and to really come together and use the enormous value of health data to improve treatment strategies in different disease areas, and also to have a good horizon scanning, an idea of what kind of new innovative therapies are coming to patients and health systems, so that everyone can prepare. And to look in detail into some of these areas specifically, PROs, patient-reported outcomes, is of growing importance when it comes to developing new medicines and making sure that they are valued appropriately. And I think specifically for chronic diseases, it's extremely important to have the patient-reported outcomes, because this is really what the outcomes that are important for the patients in terms of quality of life, functionality, ability to work, ability to live a normal life. And this is not something that you can measure from a lab test, and it's not about crude mortality data. It's really about the quality of life, and we can see already that patient-reported outcomes is growing in importance in terms of clinical research, developing new medicines, but also for HTA agencies and payers. But this needs to continue. We can see that it kind of varies across Europe. How much importance is put into patient-reported outcomes when it comes to HTA valuing the value of new medicines and getting it reimbursed. And this is something where I think that we need to come together and really emphasize the importance of this in different disease areas. We also need to make sure that medicines can be accessed all over Europe, and there are several ways to do this. It's important that medicines can be priced according to country income, so that there's no inequality in access between different countries. Obviously, different countries have different ability to pay, and here it's very important that the price can be regulated according to the ability to pay. And also pricing by indication, all these kind of innovative payment models. Pricing by performance is growing in importance, where you can look at where you tag the payment of a new medicine to the outcome it makes in real life, and you actually follow patients and monitor them. And there's a lot of new payment models, for instance, in oncology, where you only pay for the patients that actually respond to the new treatment. And this is a new way to ensure that the payers, the health systems, know that they get what they pay for and that they get value for their investment. I think I'm going to skip this slide in the interest of time, but I think also when it comes to health financing, we need to be much more holistic in how we finance healthcare. And as you saw in an earlier example, medicines and treatments in primary care can save a lot of money for hospitals by avoiding unnecessary hospitalization. But of course, if these are two different budgets, there's no logic in the financing system to actually for the primary care to make this investment, because they don't see the savings in their own budget. So we must move to much more holistic budgeting in our health system to make sure that the investments that make sense, and it's often about preventing people from getting ill or to get to a worse state of their disease, that investment makes sense for the budget holders. And today we have too many small budget holders in our health systems who have their own little apparatus to govern, and they can't and they don't have the tools to take into account the broader picture. And finally, as I said, horizon scanning. And I think we must work together to better understand what's coming in the R&D pipelines of the industry so that health systems can plan. And this is not only about budgets, this is also about, for healthcare professionals, hospitals, the health organizations can plan, because sometimes you need to completely reconfigure a patient pathway. It's, new trainings need to be put in place. And here I think we can do more together. And this is really about having a dialogue between all stakeholders about what new innovation is coming, how will that impact me, for physicians, patients, the payers, of course, the providers of healthcare, policymakers, and the industry to together have a dialogue of how new innovative treatments will impact health systems and patients. And I think for this in this spirit, last year a number of health policy organizations in Brussels joined together in what is now known as the EU Health Coalition. Then 28, now I think we're about 30. And we're really welcoming new organizations to join our broad tent. As you can see, patients, researchers, healthcare professionals, industry, the local and regional health authorities, and many more came together to put down some recommendations for EU health policy for the new Commission and Parliament. And we are still going at it. We're very active and are now working on a new EU Health Summit in 2020, where we're going to come back to these recommendations. Here you can see the top 10, where everything from prevention to health systems strengthening. And I want to highlight specifically the last point, where we said that the Commission and Member States should set up a high-level forum for better access to health innovation, because we think that there is missing today a forum on European level where member states and national authorities can sit together with the European institutions and stakeholders, patient organizations, industry, and talk about the access to new treatments and healthcare broadly across Europe. What is working, what is not working, how do we fix it? And that is something we really hope, and we were very encouraged to see that the new health commissioner has in her mission letter to really work on access to therapies across Europe, and we believe that for that to really work, we need to have this high-level platform where we can all come together and discuss these issues. And on that point, I think I will end my presentation. Thank you very much.
Well, thank you very much indeed, Thomas. A lot for us to think about there. We're going to go straight into our second keynote address. We will then take a few questions, and then we're going to introduce our next interview session. But thank you very much for that really extraordinarily informative discussion. Turning now to an academic friend coming, Professor Jan de Meijsenaar has dragged himself away from the beautiful university town of Ghent and has come to Brussels. A long journey, sir, and we're very grateful to you. And again, we're very much looking forward to your remarks. Please. Thank you.
Thank you very much for this invitation. Good morning. Just telling you something about my background. I am a family physician that worked for 40 years in one of the most deprived areas of the city of Ghent in an interprofessional team. I'm also an academic. I'm professor in family medicine and primary health care at Ghent University. The views I present here are my own because there's a lot of organizations I'm involved with. Let me just share some ideas in order to look what would be the perspectives for the future. And of course, we have a successful perspective because we are getting older. And I don't want the elderly to be blamed for the costs in healthcare. They are the success story of our system. And as I'm 67 now, I enjoy that more and more, that I'm part of that success story. And of course, we made that happen because we had good care models. The chronic care model developed by Wagner learned us, certainly when it comes to single diseases, to address the issues, for instance, for people with RMD. And all things are now well established. You need a health system, a good organizational model. You need resources and policy, it was mentioned already. You need, very importantly, self-management support. You need a good delivery system design. You need decision support, and artificial intelligence certainly can play a certain role in that. And, of course, very strong clinical information systems that talk to each other. And there's some work to do in that field. In order to realize what the Americans call productive interactions, we would say human interactions between informed, activated patients on the one hand and prepared proactive practice teams. And I think it is more and more a team and not an individual, and in order to contribute to better outcomes. And as already mentioned by Ian, there is a new fact in the present. It is no more alone about people with single diseases. Multimorbidity is the rule and no more the exception. 50% of the 65 plus have at least 3 conditions, 20% have at least 5 chronic conditions. And in this study on epidemiology of multimorbidity, having more than two or more chronic conditions, clearly shows that we are facing a tsunami. These are people with 1 condition, 2, 3, 4, 5, 6, 7, 8. And you see it increases according to the age development. So it's there, and we have to live with it. And the complicating factor and a new challenge is that you see for each of the age groups that the percentage of people with multimorbidity in the lower social classes are much higher than in the higher social classes. So a kind of double challenge, a morbidities challenge and a social challenge. And I think that's what we are facing. And RMD diseases and patients are an important part because a lot have multiple conditions. So the challenge is now, how are we going to deal with these people with multimorbidity? And so let's look again at our model. And okay, what we did is we improved and we made the patient stronger. And I think that's a very important thing. We start from the patient and we empower patients. And we did that. And of course, on this slide, it looks simple, but it takes a long process. And you have to involve all kinds of strategies to empower people because it's essential in the care. But when I look at this slide from my side, I see something different than you do. I see this. Our system does not reach what matters to the patients. And I think that's the big challenge today. Even when we apply all the guidelines that are available, we miss the point. We are not providing care that matters. And let me share with you the story of Jennifer. Jennifer, a patient in our practice, 15 years ago, she lost her husband, and she is already ever since in our practice. She has been through a laborious medical history, operation for coxarthrosis with a hip prosthesis, hypertension, diabetes type 2, COPD, osteoarthritis, and so on. Moreover, through osteoporosis, she lives independently at her home with some help from her youngest daughter, Elizabeth. And as a family doctor, I visit her regularly, and each time she starts saying, "Doctor, you must help me." And then follows a succession of complaints and unwell feeling. Sometimes it has to do with the heart, another time with the lungs, and then the hip. Each time I suggest, according to the guidelines, all sorts of examinations that did not improve her condition. Her requests become more and more explicit, and my feelings of powerlessness, insufficiency, and spite increase. Moreover, I have to cope with guidelines that are contradictory. For COPD, she sometimes needs corticosteroids, which worsens her glycemic control. The adaptation of the medication for the blood pressure, at one time too high, at another time too low, cannot meet with her approval, as does my interest in her fast hemoglobin and lung function test results. After so many contacts, Jennifer says, "Doctor, I want to tell you what really matters for me. On Tuesday and Thursday, I want to visit my friends in the neighborhood and play cards with them. On Saturday, I want to go to the supermarket with my daughter. And for the rest, I want to be left in peace. I don't want to change continually the therapy anymore, especially not having to do this and to do that." In the conversation that followed, it became clear to me how Jennifer had formulated the goals for her life, and at the same time I felt challenged how the guidelines could contribute to the achievement of Jennifer's goals. I visit Jennifer again with pleasure ever since. I know what she wants and how much I can merely contribute to her life. Ladies and gentlemen, do you know Jennifer? Yes? I think we all know her. And if I sum up the guidelines for the 5 conditions, evidence-based, I come up with this kind of agenda. There are a lot of clinical tasks to perform by the professionals. The patient has a lot of tasks to perform: joint protection, avoid environmental exposure that might exacerbate COPD, and so on. There is a patient education program, food care, osteoarthritis, COPD. There are referrals for physical therapy, ophthalmologic examination, and so on. And there are 11 different medications and 22 intakes a day. Ladies and gentlemen, my question is there life apart from the disease? And I think that is what we are facing today. And so, already in 1991, Jim Mould wrote this important article on goal-oriented medical care, where he stated very clear, we have to stop with this disease-oriented approach and start from the life goals of the patient, certainly in people with multimorbidity. So the definition of health is the maximum desirable and achievable quality and/or quantity of life as defined by each of the individuals. The measures of success are not only the accuracy of our diagnosis and the appropriateness of the treatment, but the achievement of the individual life goals, and the evaluator is not a professional, it's the patient. And what really matters for patients, we see it from our research, is functional status and social participation. And I think the theme of this conference is at the heart of these findings. It is about inclusion in social and economic life, and that requires functional status and social participation. And so I think that the International Classification of Functioning, by the way, who knows the Red Book? I think quite a lot here, of course. Will become probably in the future more important for our decisions than the International Classification of Diseases, because functional status is what matters. And I'm not going into detail, but of course when it comes to inclusion at the social and economic level, all these things on functionality are extremely important, including also the contextual factors. So we have to face an evolution from chronic disease management, what we did before, to participatory patient management, putting the patient centrally in the process. But there are a lot of obstacles. There is the fragmentation of our healthcare system. That's the way we are organized. And the previous speaker already said, it's all in silos. And all these silos have their own rules and their own budgets and their own ways of dealing with. So we need to integrate this in comprehensive primary care, because those silos, they create duplication. They lead to inefficient facility utilization and lead to gaps in patients with multiple comorbidities. And finally, not at least, they lead to inequity between patients, inequity by disease. In Belgium, unfortunately, when you have hemiplegia, it makes a lot of difference if the cause is brain tumor or if the cause is stroke, because we have a cancer program. And that makes all the difference in your access to therapy. This inequity of disease we should be very careful of, because it's us, the health system, that creates it. So it should really be an integration of these programs in the context of integrated primary healthcare. And that's why primary healthcare becomes more and more important in our health systems, because that's the place where we can integrate all this. And with the expert panel on effective ways of investing in health that I chair, we therefore made a special report where we said, well, this primary healthcare should be strengthened. It is provision of universally accessible, integrated, person-centered, comprehensive health and community services provided by a team of professionals that are accountable for addressing a large majority of personal health needs in the context of family and community, and looking at the overall coordination of the patient's care. And the team of primary care providers has to take responsibility for that. And that requires action at different levels. It all starts at the nano level. The individual interaction of the provider with patient is still of utmost importance. If you ask people, how was the quality in the hospital? The answer will be, the person on the desk was friendly, the nurse listened to my questions, and the doctor looked at me. And I think we should not forget about that. I had the privilege to work in a community health center where we took care of 6,400 people from 95 nationalities with a team of different disciplines in a highly accessible, low threshold approach, where we had an integrated needs-based capitation. And that's very good that you have integrated payment systems, because that stimulates coordination, and the patient requires coordination. He has not isolated problems. And this team works together with all disciplines, physiotherapists, occupational therapists, dietitians, dentists, family physicians, social workers. It's very important. Providing integrated care starting from the life goals of the patient. And that means that you really look at what matters to people, and that you use interprofessional discussions with all the disciplines in order to plan the care appropriately, of course, putting the patient in the driver's seat of the process. This also requires integrated shared electronic patient records, and I think that we should change also the design of our records. Our proposal is to start from the patient personal life goals in our record, and to make that a starting point, and that we link all our information about diseases to the objectives that are shared by the patient and the team, so that we see to what extent all our interventions contribute to the achievement of the objectives and to the achievement of the life goals of patients. And I think this new kind of design should really change and underpin the approach that we have to health care and involve the patient in each of the phases. In order to make primary care stronger, we have to organize it also at the meso level. In the Flemish region in Belgium, we started now a project where we have a region of 100,000 people where primary care is accountable for. And this accountability really stimulates also the cooperation and makes the contribution of primary care more transparent. And that's the way we actually organize the primary care in an integrated way. And patients can choose for their primary care networks where they face interdisciplinary teams that share information so that they are sure that they can access all services when they are in need. And the entry point is the GP, as in many other countries. And that means also that at the city and the local authorities level, you will have to discuss about healthcare, because it starts all in the neighborhood, it starts all at the family level, it starts there where people live their lives. And it starts also at the workplace, and I think integrating the workplace, as this conference puts as a very important thing, is essential in order to make people's life worth living. And of course, at the macro level, this will cost money. And it's already said by the previous speaker. And therefore, I think it's so important that we really have brave perspectives for the future. I think that anyway, healthcare will cost more in the future. Whether you like it or not, if your demographic changes are continuing, every country in Europe will have to spend 10 to 15% of their GDP. And that's an investment, that's not a cost. I think that we should see it that way in the future. And also we should redistribute our resources. Actually, in most countries, primary care has 14% to 15% of the total healthcare expenditure. I think that should increase to 30%. And of course, this has to be accompanied by a 20% decrease in hospital beds. I think the next decade is a challenge to make this happen. And Europe maybe can help us in order to cater for the transition cost, because that's very difficult. Affordability of payment for innovative medicines, it was already said by the previous speaker, is important, and we just had a case about a very difficult situation of medication of 1.9 million euros, and there was fundraising and crowdfunding, but really did this challenge the actual system. And I would like to invite industry to go further and to think to new ways of development, production and payment of innovative medicines. Should we not think about the delinkage of research and development on the one hand and production and sales on the other hand? Should we not think about price negotiations at European level in order to avoid also the problems with stock and provision of certain medication that we face today? Should we not avoid co-payments that lead to catastrophic health expenditure for patients? And should we not learn from good practices like the Coalition for Epidemic Preparedness Innovation as it acts now for the medication? And at the end of the day, any health system, its final value and society is that it should contribute, as I wrote in my book on family medicine, primary care, at the crossroads of societal change. It should contribute to solidarity, to connectedness, and to resilience of communities. If our healthcare systems are able to do that, I think we respond to the mission that we have. Thank you very much.
Thank you. That was fantastic. Now, we're going to take just a couple of minutes for some short questions and answers, if there are any. We have roving reporters with microphones, and our first question is to my right and the left at the back. Thank you. To the gentleman in the blue shirt at the back. Thank you.
Hi, my name is Rob Walton from UCB. I was really interested in Thomas from FPA's remarks around affordability and innovation, and particularly the suggestions around annuity-based payment. It's interesting to me that most public sector ministries at government level, if you're looking to invest in public finance route, use methods like bond finance to take advantage of net present value, amortization and depreciation. And I'm just wondering, what is stopping us here in the world of RMDs to take advantage of that lead and follow that? I just wondered if the panel had any views.
Thomas.
Yeah, thank you. Yeah, it's on. So thanks for this question. So I think that's very important for some of the new types of treatments, and it's not only medicines, by the way, where you can start to see that we get some curative treatments. I mean, we have new cell and gene therapy that will replace a life course of treatment with a one-off, very high-tech treatment that has a high upfront cost, but will save money for the health system in the long run. And many times our financing models in the health systems are not made to do this. They can't handle this equation. They have a yearly budget, and when the yearly budget is up, it's up. And it doesn't matter that they will save money in the long run. And I think that obviously this differs from member state to member state, but I think in some countries there are even legal difficulties in doing that. And I think so there's a lot more creativity needed. I mean, in itself, it's not a complicated thing, and some bright minds could easily figure out how to do this. But it just needs to have the right system enablers and the flexibility in how payers pay for healthcare to make that work. But I think that's a very important conversation to be had.
And that's going to become even more complex when we talk about preventative therapeutics. What price the prevention of a chronic disease? There was a question in the middle, in the blue blazer, this gentleman here. Thank you.
Hello, Professor Lidson from the IMNRC. I'm a neuroscientist with a medical, philosophical, musical, and scientific training. Actually, the term neuroscience, to my mind, is obsolete. We should refer to the nutri-neuro-immunovasculo-endocrino-epigenetic system because you cannot possibly dissociate one from the other. Cross-stakeholder dialogue, yes, but why limit this to the European silo? I mean, work R&Ds, this is a global challenge, not exclusively European. And finally, well, I question sometimes the competence of physicians. To my mind, I mean, is medical training fully adequate to deal with the complexity of medicine and to enable a holistic approach to the patient? I'm not so sure. Medical training is still terribly fragmented, not to mention the chronic lack of suitable pedagogues. So to my mind, there is a need for a fundamental education revolution, not just in medicine, but in education, period. Thank you.
Thank you for your remarks. Maybe Jan, you'd like to respond to part of that?
Yes, of course. I fully agree. We should not do it only in the side of Europe, and I hope that we can find in other continents similar interest in policymakers to have a more joint approach and to really learn from each other and make progress for all people and all the continents in this world. I think that's very important. When it comes to your point of competence, I fully agree with you. I had the privilege in 1999 to fundamentally reform the undergraduate medical curriculum at University in Ghent, which was awful at that moment. And we had the best that ever happened was that we had a very negative report by the international assessors that came to visit our training program. And we completely changed it. The first thing today that the students see when they come in their first day to the university is that they listen to the story told by a patient about what it means to have chronic conditions. And so that's the starting point of their training program. And we build it up in an integrated way so that we always look at the different dimensions. Another important thing is, from the very beginning, the training is interprofessional. Looking at different things. Already in the first and the second year, they learn to use the International Classification of Functioning framework, the broad framework, not the disease.
You begin with a holistic approach.
Yes, that's from the very start. That's what the first clerkship they do is in a nursing home for the elderly, to see how patients face this condition and what it means at that moment and what they expect from at the level of health care. Also, we have a lot of interest to social determinants. Our students go to deprived area, do community projects over there. And I think that this kind of preparation helps the students to see the importance of a holistic approach. And of course, this shift that we now make from a disease-oriented to a goal-oriented care, it's about achieving the life goals of the patients, and that brings them to what really matters to people. The question is no more what's the matter with Mrs. Johnson, but what matters to Mrs. Johnson. And I think that shift is very important.
Thank you. I've often said that, so rheuma is flow. And rheumatologists are amongst the most remarkable of physicians because our diseases challenge so many systems and because we enter the discipline knowing there are no cures for any of the conditions that we will treat, actually not dissimilar to some of the challenges that you face in neuroscience. You raised so many pertinent issues, but maybe one remark to your concept around the European silo. It's a real pleasure to have friends from the American College of Rheumatology in the room today. And I think one of the success stories of the last decade has been an extraordinarily engaged conversation in the global world of RMDs. And so with ACR, with our friends in Asia, in APLAR, in PANLAR in South America, and now increasingly with AFLAR in sub-Saharan Africa, where there is almost no attention to RMDs, a discussion for another day. But your request that we break the silo is well taken, and we believe we've well and truly broken it. We'll take one final question, Professor Burmester.
Yes, it's so my name is Gerd Burmester. I'm a rheumatologist from Berlin. I'd like to ask a question to Dr. de Messner. How will you integrate aspects of digital medicine into primary care and interaction with specialists? Many of our patients already come with their own diagnosis built on Dr. Google or ADA system. They have wearables, they have remote ECGs in their watches and so on. So how will we integrate it and use it? Because some patients like to interact first with a computer rather than with a human being, which sounds strange sometimes, but I think that's already there.
I think this is a very big challenge. Of course, the solution is not to run away from new technology, but to look critically to what extent it is able to contribute. And I think also another thing is we should start with quaternary prevention. That means avoiding that we induce illness and disease to patients. And of course, the risk, if you monitor everything at any moment, that there is nothing more in life than looking at your smartwatch to see what your anxiety level is, what your heart rate is, and so on. So that's not the future for life. On the other hand, I think it enables us to better look at patients in their home care environment and the telemonitoring and all kinds of things. And also it contributes to make patients more independent in formulating their life goals. I dream of a situation where patients on their smartphone have an app where they write what really matters to them, and that immediately is in their health record, so that they come to see a provider, they can start from that. And I think that would make a huge change at all levels, at the emergency department, but also in our daily practices as specialists and as family physicians, in the way we approach our consultation. But I don't find somebody to develop that, but that would really make, I think, a very fundamental redesigning of our interaction. So as far as technology helps us to improve and redesign and make our interventions more efficient and more patient-centered, I think we have to go for it.
Thank you very much indeed. Now, one of the consequences of having a Glasgow chair is that I'm going to be very rude. And I see many other questions in the room, but I'm going to beg your forgiveness. We will take those questions as the day goes by, but I'm very keen to hand over to someone who actually knows what they're doing when they're chairing a session. And so may I ask you all to join me in thanking our speakers, Antonio, Tomas, and Jan, for such a stimulating start to the day. And thank you very much indeed.